All right, welcome back. Last time went a little long. So anyway, this time broke it up into two parts. We left off talking about sickle cell anemia, and so this time we're going to continue in that theme. So in terms of erythrocyte disorders, remember erythrocytes are your red blood cells. In terms of erythrocyte disorders, they can broadly be categorized or classified into either anemias or polycythemias. And so an anemia, as you can see there, is when the blood's oxygen carrying capacity is too low. So sometimes it's an actual shortage of red blood cells, but it could just be something relating to the red blood cells that's limiting their ability to carry oxygen. And then polycythemias, on the other hand, are usually that you have too many actual red blood cells. So you could view it as being able to carry too much blood, which is the case in at least one particular polycythemia. But polycythemia, you got too many red blood cells. So anemia is can be viewed as a shortage of, or at least a shortage in their capacity to carry oxygen, and then polycythemias are too many. So speaking of anemias, and since we left off talking about sickle cell anemia last time, so in terms of limiting the blood's oxygen carrying capacity, there's a few ways to go about doing that. One is obviously blood losses. So if you lose a bunch of red blood cells, well, then you don't have near as many to carry oxygen, and so then that impairs the blood's oxygen carrying capacity, and then results in symptoms that we would expect to see with reduced oxygen carrying capacity, which the primary one is going to be fatigue. So if you can't deliver enough oxygen to the tissues, you are going to feel fatigued. You can't produce as much ATP, can't produce enough of the energy molecule, and so you're going to feel tired. If you're an athlete, you're not going to be able to perform at as high of an intensity. And something else that you're going to see is probably a higher heart rate at the same intensity, where if you weren't anemic, you would have a lower heart rate at that intensity. So basically what the heart is having to do is turn over the blood more rapidly if the blood can't carry as much oxygen. So then that's why you would expect to see a higher heart rate offsetting that reduction in carrying capacity. So with blood losses, you're going to see an increase in heart rate to accommodate that. So that'd be one thing, but of course that would be fairly unusual in an athletic context. So that could be blood losses related to obviously some kind of a significant injury, but that could also be something like related to an intra-abdominal bleed. Maybe somebody's got a perforation somewhere in their intestines or in their colon that is leading to bleeding inside of the abdominal cavity. So blood losses could be related to that as well. Other types of anemias, so maybe you just don't produce enough red blood cells, or inside of the red blood cells, you're not able to produce enough hemoglobin. So remember, hemoglobin is the molecule that actually binds to the oxygen inside of the red blood cells. So it could be you're not able to produce enough red blood cells, and more specifically, you're not able to produce enough hemoglobin because you have an iron deficiency. So remember last time we talked about all of the ingredients that you need in order to make red blood cells, because you're churning out more than 1 billion per day. So you need, the normal macronutrients, right? So you need carbohydrates, fat, and protein. But in addition to those, you also need iron for your little heme groups. And then we also talked about the need for B12 and folic acid or folate, because both of those two are involved in DNA replication. And if we're making a bunch of copies of erythrocytes when they're young, we have to replicate a bunch of DNA. And so just generating that many cells requires really rapid DNA replication, and so we have to have the necessary vitamins to do that. So that includes B12 and folic acid. So again, could be iron deficiency. Iron deficiency oftentimes is related to diet. We talked about different dietary sources last time, and that's this week's discussion board is related to iron deficiency anemia. So I won't tell you any more about that. We talked also about pernicious anemia last time, and that is that you don't have intrinsic factor in order to absorb B12 in the intestine. So remember that intrinsic factor is secreted by cells in the stomach, and then once that intrinsic factor gets into the small intestine, it'll bind with B12. Once intrinsic factor is bound to B12, we can absorb it, and then again, that's going to play a crucial role in cell reproduction. Another possibility is you've got too many red blood cells destroyed. So we talked about that actually with sickle cell anemia would fall under that category. So the cells that have sickled are effectively destroyed red blood cells. They can't do what they're supposed to do as far as carrying oxygen because of all of those spiked hemoglobin molecules and then the sickling of the red blood cell shape itself. So that would, sickle cell anemia would fall under the category of too many red blood cells destroyed. There's also some other congenital ones. So thalassemias are another congenital one. And so in that case, you make red blood cells that just aren't as hearty, if you will. They're more easily destroyed. So they're thin, they're delicate, and then deficient in hemoglobin. So it's easy for them to fall apart. And so because of that, the turnover rate is faster. So in terms of anemias, then in terms of reducing the blood's oxygen carrying capacity, it could be because you just straight lost blood, right? Or it could be not making enough, or we're losing them too quickly. So any of those things will impair your ability to carry oxygen in the blood and will thus lead to an anemia and produce the symptoms I mentioned a minute ago. On the other end of things, we've got polycythemia. So polycythemia is some sort of an abnormal excess in red blood cells. So you've got too many of them. And so a few things go on there. One of the big ones is that the blood increases viscosity. So you get the blood is more like syrup, right? It's thicker because you have more of those formed elements. Specifically, you've got more red blood cells in there, and so it's harder for the heart to pump. And so obviously that's problematic. One of the, I guess, more common types of polycythemia is actually related to cancer. It's called polycythemia vera. And so in that case, it is a cancer in which the red marrow is just pumping out tons and tons of red blood cells. And then why that matters is those crowd out the other cell types, and then eventually that can lead to death. But on the more positive side of things, in the 1960s and early 70s, there was a Finnish cross-country skier whose name is Eero Mäntyranta. I don't know if I pronounced that right, but you can see his name spelled there at the bottom of the slide, and this is him. So he was an Olympic athlete between 1960 and 1972. So in that span, he went to 4 Olympic Games as a cross-country skier representing Finland. And in those 4 Olympic Games, he won 3 golds, 2 silver, and 2 bronze medals in his events. And so he actually had a good or beneficial genetic alteration that's called primary family congenital polycythemia, or PFCP. And so what that was he was basically naturally blood doped. So we talked last time about Lance Armstrong or other cyclists doing things to manipulate their hematocrit, doing things to manipulate the proportion of their blood that's red blood cells, because the more oxygen you can carry, the more oxygen you can deliver to the tissues, you can make more ATP, so you can exercise at higher intensities for longer. And so if you're somebody like Eero, who just naturally makes more red blood cells, he was basically born blood doped. And so because of that, he was a really elite endurance athlete, as evidenced by his 3 gold medals at the Olympics. But it was just because of a genetic alteration that he produced more red blood cells than anybody else. And so one estimate that I read was that his blood could carry 50% more oxygen than many of his competitors. And so obviously that's a natural advantage that he had, and then was able to capitalize on that and to perform at the Olympics. So again, polycythemia, too many red blood cells. All right, so we'll leave red blood cells and move on to white blood cells. So white blood cells, also known as leukocytes, so those are involved in immune function. So they do things like attack invading bacteria, viruses, tumors. So if we have malformations of our own types of cells that then become a tumor, T cells in particular, under the lymphocytes, are responsible for attacking those budding, nascent, early tumors and taking care of them so that those cancerous cells then don't metastasize. That's the job of the T cells. So then leukocytes then are our body's defenses. There are the cells responsible for carrying out our immune functions. So there's 2 broad categories of leukocytes. So you've got granulocytes and agranulocytes. The difference between the two is that when you look at them under a microscope, the granulocytes look like they have little granules in their cytoplasm. So they have a little bit different appearance. So the granulocytes, again, look like they have granules. The agranulocytes, anything A is without. So the agranulocytes don't have those obvious granules in their cytoplasm. So that's the primary difference between the two. So in terms of the different granulocytes, so they're listed, or in terms of different leukocytes, they're listed under whether they're granulocytes or agranulocytes, but they're not listed in terms of their prevalence in the blood. And so this picture does that. So the first one there, under our granulocytes, those are our neutrophils. And neutrophils, as you can see here, account for 50 to 70% of our white blood cells. So those are the most of our white blood cells. And so neutrophils are primarily responsible for attacking bacteria. And so they are phagocytic cells, which means that they can actually wrap around an invading bacteria. And then once they've enveloped that bacteria, they are able to then, with different enzymes, actually pierce the membrane of that bacteria, and then they, inside of their peroxisomes, manufacture a number of oxidizing substances, including bleach and hydrogen peroxide, and so then they can use those things that they create in their peroxisomes to kill the bacteria. So the neutrophils are bacteria neutralizing white blood cells, and again, the most prevalent of our white blood cells. We got more of them than any of the others. The next one on there, the eosinophils, are smaller in number, so you can see they only account for about 2 to 4% of our white blood cells. And so the eosinophils are, one of their jobs is to attack parasitic worms or other types of parasites. So they actually will latch onto the surface of any of those invading organisms and then basically degrade the surface, the outer portion of those invading organisms and kill them. But in addition to that, eosinophils play a role in allergic responses. Actually, one of the things that they do is to sort of tamp down that response. Like so, moving on to the next one without getting too far ahead of myself. So the basophils here are similar to mast cells. So remember, mast cells, we talked about those being distributed throughout the loose connective tissue and those sort of initiating that inflammatory response in part by releasing histamine. And so one of the things that histamine does is to attack white blood cells to the area and start that inflammatory response. So basophils, even though they're a type of white blood cells, actually attract, that's what I was going for. They attract other white blood cells to come to the area and sort of initiate but also increase that immune response. The eosinophils, on the other hand, can bring it back down. So they have enzymes that sort of counteract that histamine. And so they can modulate or bring down that immune response. So that's our eosinophils. The basophils, the last of the granulocytes, there are very, very few of those. So the basophils only account for somewhere in the neighborhood of 1% of our white blood cells. And again, they're functionally similar to mast cells in that they release histamine, which, as mentioned, attracts other white blood cells, but it's also a vasodilator, so it opens blood vessels up, which is one of those things that then leads to swelling and redness in areas where we've got inflammation. Then our agranulocytes, so the two categories of them, lymphocytes and monocytes. Under our lymphocytes, we have two types there. We've got our T lymphocytes, or our T cells, and then our B lymphocytes, or our B cells. We talked about those a little bit in the discussion board on the COVID vaccine, and we'll talk about them even more. We have a special chapter on immune function, so we'll get to them more later. But for now, things to know about the T cells is that those are the ones that actually carry out the attacks on the virus itself, but also virus-infected cells. The B cells play an important role in marking cells that need to be attacked. So they generate antibodies, which then help us to locate the cells that need to be attacked. And then the last one on there are our, as far as the lymphocytes. So the lymphocytes are the next most numerous next to the neutrophils. So the neutrophils are up here, 50 to 70%. Lymphocytes, next highest in number, 25 to 45% of white blood cells. And then the last one there are our monocytes, the really big ones. And so those only account for somewhere between 3 and 8%, but they are the big eaters. So those are the big cells that will go through and when we talked about inflammation, if there's damage to the tissue and there's collagen fibers that need to be sort of chewed up or gotten rid of to help clean up the area, that's the job of the monocytes. So they'll go through and clean up any debris, but they can also attack invading bacteria and other organisms as well. All right, so there's those. Okay. So if the red blood cells can have disorders, so can the leukocytes. So the most common leukocyte disorder that you would be familiar with I guess not most common in terms of what percentage of the population has it, but one of the ones that you'd be familiar with the terminology would be leukemias. So leukemias can be either acute or chronic, and what those terms describe is how quickly that condition advances. So acute leukemias progress really quickly, as opposed to chronic leukemias progress much more slowly, so they get worse slower. So acute leukemias, unfortunately, are typically seen in children. If kids get leukemia, it's typically fast advancing. In the elderly, it's where we see chronic leukemias, and those are typically slower advancing. And so in any of those things, you've got basically too many white blood cells. And so you can see the normal blood here, all of our little red blood cells, our platelets, and then we have some of our white blood cells here. And then in leukemia, we've just got tons and tons of white blood cells. And effectively what they do is then they crowd out everything else in the blood. So they crowd out the platelets, they crowd out your red blood cells, and so you can't carry oxygen in the blood very effectively anymore. You also, because they crowd out the platelets, you also can't clot the blood very effectively. And even though you've got tons of these white blood cells, they're immature white blood cells, so they can't actually do the things that normal white blood cells do. They can't attack viruses, they can't attack bacteria, even though you've got tons of them. And so people who have leukemia are susceptible to infection because while they have lots of white blood cells, they don't do their job. And so actually one of the things that, in addition to an infection that tends to be the resulting cause of death in leukemia, is bleeding disorders, or not bleeding disorders, but internal bleeding or hemorrhaging, because again, those white blood cells in leukemia can crowd out the platelets, and so then we can't clot the blood anymore. So acute leukemias are fast developing, chronic leukemias are slow developing, and they can either be myeloid or lymphocytic. What does that relate to? That's describing the particular cell that's proliferating too fast. So your myeloid leukemias are everything other than lymphocytes. So your eosinophils, your basophils, your neutrophils, or your macrophages you're making too many copies of one of those cell types with myeloid leukemia. With lymphocytic leukemia, you have either too many T cells or B cells. But again, they're non-functional, but it's one of those types of cells that you're making too many copies of. In another leukocyte disorder, so you've got mononucleosis, the kissing disease, so you may be familiar with that one. Typically affects young adults. It can affect anybody, but typically it's seen in young adults. The reason it's called the kissing disease is because it's spread primarily through saliva. It can spread through other bodily fluids as well, but it's primarily spread through saliva, so like from actual kissing, but also from like sharing water bottles. Anything where you come in contact with somebody else's saliva can result in spreading the virus that causes it, which is the Epstein-Barr virus. And so what we get with that is once that virus is inside of the mouth, it migrates into the epithelium, so that lining tissue inside of the mouth and throat, and then gets inside of those epithelial cells and reproduces there. Once it's produced a bunch of virus inside of those epithelial cells in the throat, number one, it's going to cause one of the primary symptoms of mono, which is a sore throat, because of the attack of those cells inside of the throat and then the resulting inflammation. But it also then spreads deeper to those tissues and makes its way into the bloodstream. Eventually, it makes its way into the B lymphocytes, which is where it reproduces. So it's going to make a bunch of copies of itself in the B lymphocytes, and it actually is able to spur those B cells to make more copies of themselves. And so you get lots and lots of B cells that are then basically little virus factories that produce more and more of it. And then we make a whole bunch of T cells in response to that. And so basically, in response to this virus, you see this huge proliferation of T cells and B cells, the B cells because they've been hijacked and the T cells to fight them. And so one of the things that can happen there, one of the primary symptoms other than the sore throat with mono is fatigue. People feel really, really tired. And there's a couple different reasons why that might happen. With that explosion, if you will, of T cells and B cells, that can crowd out some of the function or some of the production of red blood cells in the red marrow because they're all produced in the same place. So that can kind of crowd out your erythrocyte production. And with lower erythrocyte production, lower oxygen transport, start to feel tired. But another thing is there's a defensive mechanism in the body where we actually just downregulate the production of all the blood cells to try to slow this process down. And so that helps sort of blunt the increase in B cells, but it also then reduces the production of erythrocytes, which then produces that feeling of tiredness. And then the other thing on there, splenomegaly. So your spleen has a few jobs. One is to filter or sort of clean up the blood. So any of those non-functioning or aging red blood cells that we need to get rid of, that's the job of the spleen to do that. But in addition to that, the spleen also functions as a site for lymphocyte production and storage. And so if you've got massive production of B cells and T cells and lots of B cells or T cells to be stored, the result is that the spleen grows in size. The spleen hypertrophies temporarily. And so the spleen is a solid organ, so it's pretty hard. So solid organs are things like your liver, your spleen, your brain, as opposed to hollow organs like your stomach or your intestines. And so the reason that matters is if your spleen is full of all of these blood cells, it's enlarged, if it's struck, it's more likely to lacerate, to rupture, right? And so then we can get bleeding into the abdominal cavity. Obviously, that's bad. And so somebody who has mono typically is excluded from sport participation, usually for somewhere in the neighborhood of a month, because of this danger of spleen rupture if they're struck while their spleen is enlarged. Now, of course, if they feel bad and they are feeling tired all the time, well, they're probably not playing sports anyway. But that's the reason if you have mono why you can't play sports is because of the risk of rupture or laceration of the spleen because of the swelling, since it's all full of T cells and B cells. One of the other things I wanted to mention before I forget, so with the leukocytes, we can ramp up production of those if there's an infection. We can ramp up production of those really, really quickly. So you can basically double the production of those blood cells within a few hours. And why I wanted to mention that is because one of the symptoms that we associate with infection, so if you get the flu, if you get COVID, if you get another number of other things, one of the symptoms that we commonly associate with those things is body aches, right? So your low back hurts, your bones just hurt, like everything just hurts. I don't know about your experience, but typically for me, it's like low back pain is something I never normally have, knock on wood. But when I get sick, like that's kind of one of those like, oh, it's coming. I'm starting to have some low back pain. And then you get general achiness and all of that. And so what's going on there is that's your body ramping up production of white blood cells to fight the invading pathogen. So it's not the virus itself, if you got the flu, it's not the virus itself that's causing that sort of achiness. It's actually your own production of white blood cells trying to fight that invading virus. And also your white blood cells actually produce a number of the other symptoms that we associate with being sick. We'll stick with the flu. So oftentimes you'll get a fever with that. Some of the chemical messengers secreted by the white blood cells cause your hypothalamus, which is, we'll talk about it a lot more later. Or actually, we talked about it a lot. That's a lie. We talked about it in 201. Among the things that the hypothalamus does is your body's thermostat. It sets your temperature at 98.6. And so through chemical messengers secreted by the white blood cells, we can actually set that temperature higher. And so you can set that temperature to 102. And so you'll let your temperature rise up to 102. Now you've got a fever, and then if it drops below 102, you start to feel cold, right? So why do we do that? There's a few reasons that the chemical messenger cascade does that. One of those is that some organisms don't reproduce nearly as well when they're inside of a really warm host, and so that's part of it. It's partly defensive mechanism. But another thing is that by increasing our temperature, that's also then going to spur the production of another chemical messenger called interferons, which are released by virus-infected cells. So we'll stick with the flu example. So if you got the flu that has infected cells throughout the body, those infected cells release interferons to let the T cells know, hey, I'm infected, come take care of me, right? So come basically kill me so this virus can't spread anymore. And so by increasing our temperature, that increases the production of interferons, which then ramps up the activity of the T cells to attack all of those infected cells so that we can get them taken care of and limit the proliferation of the virus. So that's the reason you get a fever there. All right. So you get general kind of achiness because of that increased production of these white blood cells, trying to help yourself out. So it's not the virus doing it, it's actually your body's defense to the virus that causes you to feel crappy. for most of your symptoms anyway. All right, and then platelets. So some of this stuff we talked about when we talked about immune function. So your platelets, as you can see there, are fragments of cells. They're not entire cells themselves, but they're cell fragments that help stop bleeding. And so what happens is, again, inside of the red marrow, you have, in addition to making red cells and white cells, you have another cell type called megakaryocytes. And megakaryocytes are obviously really big cells, and they will, once they've grown large enough, actually send projections out of the marrow and into a nearby capillary, which then the projection basically breaks off in that blood. And so you've got just this, the book describes it as leaves blowing in the wind, but you've got this just pushing through all these cell fragments that have fallen into the blood, and then because of the chemical characteristics of phospholipids, they're then going to self-assemble into little membranes, and so they're kind of like cells in that they're a little phospholipid bilayer, but they don't have any of the organelles. They don't have the nucleus, the mitochondria, etc. They just are a little cell membrane with a bunch of chemical mediators inside. So the ones that stimulate inflammation, the ones that attract white blood cells, those kinds of things. So if we have damage to a blood vessel, so remember that the lining of a blood vessel is called the endothelium. And so normally the endothelium is kind of like Teflon. It's really slick. There's nowhere for our white blood cells or our red blood cells to stick to the endothelium, and so all of them just keep moving along, which is good. We don't want things plugging up the blood flow. So in a normal, healthy endothelium, everything just slides right past it. But if there's damage to the endothelium, so the endothelium, you can see, so here's one of the little endothelial cells here, here's another. So if there's damage to the endothelium, then that is going to expose underlying collagen fibers, because there's a basement membrane underneath that endothelium, and so that'll expose underlying collagen fibers. So when those collagen fibers are exposed, that sort of activates the platelets. So any of the platelets floating by are then going to stick to those collagen fibers, and then once the platelets stick to those collagen fibers, they're then going to release ADP, which stands for adenosine diphosphate. And once they release ADP, well, that's going to attract other platelets, so that'll help us plug up this hole. And in addition to that, they being the platelets, are going to secrete serotonin. And so serotonin is going to make it easier for those additional platelets that are coming to stick to the original platelets. And so the platelets then, once they've adhered to the collagen, start this signaling cascade that says, we've got a hole here in the vessel. We need as many of you other platelets to come as possible. Everybody comes and everybody sticks. And so that forms the original plug, which is pretty strong, but not as strong as it could be. So in addition to that, so again, these platelets are basically just these little bags of chemical messengers, essentially. And so then among the other things that the platelets release, they're also going to release another chemical messenger that's going to activate fibrin, which normally floats around in the blood. And so then fibrin is going to become threads that'll actually run between the little platelets. And so you can see, here's our fibrin clot here. So all these are the little fibrin fibers, and obviously these are your red blood cells. So then they help kind of glue up everything, help everything stick together, form sort of a spider web there to help close up the clot. And then your platelets also have the two contractile proteins we talked about in muscles. They have actin and myosin as well. And so then they will start to pull on those fibrin threads and cause the clot to retract, cause everything to kind of close down and lock it up. And then once we've stopped the bleeding in that clot, or because of that clot, then the platelets are also going to secrete a couple other chemical messengers, because again, they're little bags of chemical messengers, and so they're going to release platelet-derived growth factor, and so that is then going to cause the smooth muscle cells, which would be underlying our blood vessel here, that's going to cause them to proliferate, to make more copies of themselves so that we can repair any damage to the underlying smooth muscle. And then they're also going to secrete vascular endothelial growth factor, which is VEGF, and then that's going to cause reproduction of some of those endothelial cells so we can repair the damage to the endothelium as well. Here's a little clot. All right, just a quick bit about blood groups. So you're probably familiar with blood groups in terms of the lettering system. So there's 4 basic blood groups. So there's A, B, AB, and O. Those are the 4 basic blood groups. And then there's also a positive or negative. Okay, so that's, you could be A positive or B negative, etc. So the 4 basic blood groups then, A, B, and O, or A, B, and O. And so what determines what blood group you're in? It depends on the particular antigen you have. And so type A blood group has type A antigen. And so the antigen is something on the outer surface of the red blood cell that marks it as our cell. So think back to when we talked about the glycocalyx, that sugar covering of the cell, and that the glycocalyx also includes glycolipids and glycoproteins. And so those then are sort of the cell's fingerprint. And so antigens, same concept here. So you have a series of glycolipids, glycoproteins on the cell's membrane that mark it as a cell belonging to us or not. And so type A blood then has type A antigens, and so that's us. But it also has type B agglutinins, and so what those are antibodies, things that will attack, in this case, type B blood, that just normally float around in the plasma. So the way it works, I think this graphic is a little more helpful here. So if we have our type A blood over here, okay, so then you have your type A antigens, these little spikes. And then you have the antiglutenin for type B. So if some type B blood gets into the body, which type B has these little antigens here, these little make sure I get the verbiage correct, agglutinins, there we go. So these little agglutinins will then, I was down here, these little agglutinins will attack that B blood, okay? And so why that matters then is if you, have a significant blood loss and you need a blood donation, if you were type A blood and then you were given donor blood that was type B, all of your little antibodies would, your agglutinins, would attack that type B blood and cause those red blood cells to lyse, cause them to explode or degrade. And so obviously that would be problematic, and then that can lead to really profound symptoms throughout the system, and so that would be bad. So somebody who has type A blood then can't receive type B because that's going to provoke a pretty significant immune response. Similarly, so then type B blood, so here's your type B blood over here. So you have your type B antigens and then the anti-A agglutinins, or agglutinins, whatever, however you want to pronounce that. And so then if this person with B blood receives A blood, their immune system is going to attack that. If you're somebody who is AB, you have both antigens, but no agglutinins. And so it doesn't matter what kind of blood you get, you're not going to attack it because you don't have any of the antibodies to attack it. And so type AB then is referred to as the universal recipient because they don't have any of those plasma antibodies that are going to attack any other blood type. So AB can be the universal recipient because they're not going to attack anything. Type O blood, on the other hand, doesn't have any of the antigens. Basically, it's those little red blood cells are kind of stealth, so they don't really have any identification to attack. So they have, somebody who's type O has both the anti-B and anti-A, so if they get either of these or this one, they're going to attack it. So type O can only get type O. But on the plus side, if somebody's type O, because there's no antigens on the surface here, if you put type O in a person with type A, well, they only have anti-B agglutinins. And so because there's no B on here, there's nothing to attack. So type O then is the universal donor because there's nothing out here, there's no antigens, no A or B antigens expressed on type O blood, so there's nothing for those agglutinins to attack. So on the plus side, you can see that the vast majority of us are type O, so almost 80% of us are type O. Type A is the next most prevalent, followed by type B, and if you are, oh wait, I thought I had an overall, sorry. That's by race. Anyway, even among different groups, you can see that for white or black or Asian or Hispanic, type O blood is the most common, followed again by type A, and then followed by B, and then AB. So AB is pretty uncommon. The other thing on there, the Rh factor, is either positive or negative. So it's another set As you can see there, another antigen with associated glutaninins. So if you are O positive and you get O negative blood, then you would have some immune response there because you're attacking the negative. So you want to match up the positives and the negatives as well. But similar to where AB blood is pretty rare, negative blood is also pretty rare. So something akin to 85% of the U.S. population is Rh positive. So if you're O, the odds are pretty good that you're O positive, not O negative. And so actually O negative is the true universal donor. They can go to pretty much anybody. So yeah, so then that's the end of blood. See how short we kept it? Okay, good. So 35 minutes. All right, so that's the end of blood, and then next week we will move on to the heart. So thanks for watching.